Our next speaker is Ellen Harvey, CNS here at Brilliant Renwick Memorial, and her topic is going to be how implementing a progressive mobility program decreased the fall rate on in the neurotrauma ICU.
Thank you. It's a pleasure to have the opportunity to present our project to you today. It's really been a labor of love, and we're happy to share it. Actually, this journey goes back to 2011 when we began to look at progressive mobility. It became very prominent in the literature. Had not been a lot done on trauma patients, but it was starting to emerge. So we pulled together a multidisciplinary team, including physicians, therapists, respiratory therapists, nurses, and really engaged in where we wanted to go with this project. And our goal was really to promote optimal care in our population by implementing a quality, highly efficient, and effective progressive mobility program. And then the objectives were to take an interdisciplinary systematic approach and to really see what impact that might make on targeted outcomes such as falls and VTE, pneumonia, and potentially later things like length of stay. So immobility is a difficult problem. It particularly can be difficult for trauma patients because they oftentimes have complex injuries, including neurological, neurosurgical injuries, orthopedic injuries, and have multi-system problems. We know deconditioning occurs rapidly, and actually these first couple studies were done on it's usually the standard medical student that was made to live in a bed for a week. But healthy individuals even very quickly become deconditioned. And I don't know if any of you have ever had surgery. It's amazing after one day in the bed how you feel. I mean, it's just incredible how weak you get. And we know that muscle strength decreases by 1 to 1.5% per day of bed rest. So it's a pretty significant muscle wasting that occurs very quickly. And we know that of patients that fall, potentially as a result of becoming deconditioned for a variety of reasons in the hospital, 30% of those patients that fall will sustain an injury. It increases length of stay by over 6 days and is very costly at about $14,000 per fall with injury. So our baseline here, we were really, when we were starting out here, had fall rates in 11, 12, and 13, above our benchmark, when our national benchmark was the Indian QI benchmark of 1.12. So we used a DMAIC approach with our systematic steps to improve this. It occurred in our 12-bed neurotrauma ICU, and we looked at pre-post implementation, falls, and a variety of other things after implementing our Move It program. In our analyze phase, what you can see here is we found we didn't have much patient-family engagement. A few of us went to Johns Hopkins to get some training with national experts. 8 Mountain ICU was doing a similar journey at the same time, so it was wonderful that not only we got to benchmark with external experts, we then came together and benchmarked together with internal experts. But we found we didn't have a policy and procedure. We had some equipment needs for our complex patients, say spinal cord injury patients, people that couldn't get to regular chairs. We really didn't have any way to document progressive mobility in the electronic record, and we really weren't engaging our patients and families, as I mentioned. So this is a snapshot of our baseline data. This is for trauma patients and that were admitted during this time. We did 199 observations over 6 weeks, and you can see only 73% had activity orders, but of those, 54% had bed rest orders. We only had PT ordered in about half of the patients, and then you can see if there were no activity orders, most people stayed in the bed. That was the option. So we knew that we had some rooms for improvement here. So what did we do? We developed a patient-family education brochure. We benchmarked around the country, and no one really had one. So we developed one together with the wonderful help of Margaret Perry. You know, she's like just the most coolest stuff. We also implemented egress testing, and egress testing is an evidence-based test determine whether the patient is able to bear weight safely in order to take an assisted transfer to a chair. Prior to that, have any of you remember the days where you have one person on each side and you kind of do the deadlift like you do in CrossFit and then move them over to the chair? That's not safe for the patient, and it's not safe for our staff as well. So we implemented that testing to see whether or not the patient could bear weight safely enough to do so. And then we implemented a daily goals board. We actually have level for progressive mobility on our daily goal board so patients and families can see how the patient is scoring and what our goals of care are for that. We also include our families in our morning rounds when they're present. Environment of care, we implemented no lifts. So we decided as a team we were not going to be doing those deadlifts to chairs anymore. If the patient couldn't meet that benchmark, then we focus on edge of bed, building core strength in the belly sitting on the side of the bed. That's dangle for all us old school nurses that used to do that all the time. That kind of became a lost art to a certain degree. We purchased a Stryker chair with our ventilator pneumonia quality award monies, and we applied it there, got some other recliner chairs as well, so put that money to good use. And then we later were really delighted to get the progressive beds, which are kind of like the Cadillac of ICU beds that allow us to really help to facilitate that continued movement. Interdisciplinary team-wise, we adopted the Move It theme from the Madagascar. You know, when you even say that to the patients, we're gonna move it. Everybody's tapping their little fingers and everything. Collaboration, of course, is huge internally and externally. We developed a progressive mobility policy. Donna Bond had a huge part in that, and developed trauma-specific guidelines so that staff, and that is available and actually applies to all adult acute inpatient units in our hospital, and safety screening. We did extensive education, and one thing we did about this is we actually did some competency training. So for our PT/OT folks, we had them do some competency training with respiratory, so that sometimes when you get a patient moving and they're on the ventilator, you might need to suction them. Well, in the past, the OTs and the PTs didn't feel comfortable with that, so we made sure they had that training so they weren't looking for someone to come suction the patient. We also did competency training with our clinical associates so they could actually serve as PT, not actual PTA, but to assist with transferring complex patients. Maybe you need someone to hold a leg with a fracture, or how to engage in that when there wasn't a PTA available that day to help the PT. Interestingly enough, for our project, our quality project, we found that we only needed a PT about 90 to maybe 120 minutes a day. So we really didn't need a full-time PT in our unit. What we really improved on is we do a daily huddle to this day. PT comes in early on any given day, and I'll show you this is our protocol. On any given day, we found about 40% of our patients couldn't participate, but we could target those that could. So that daily PT huddle, and then celebrating, really celebrating the improvements. As far as this goes, we do have this posted on every door in the patient room so that the family can see it coming in, and we really, this kind of mirrors our progressive mobility policy with leveling the patient and what the criteria are in our unit to determine whether they're safe to move. And again, we really push this theme in our unit. So our results. We increased our PT seeing the patient to evaluate from a baseline of 23% to greater than 70% by fiscal year 2014. We found that the average PT time that the patient needed or received was greater than 18 minutes, and the literature tells you that at least 12 minutes a day is beneficial and has positive outcomes, so we were able to achieve that benchmark. And as I mentioned, about 40% of patients were level 1 unstable, and that was most often because of unstable ICP in our unit. It makes sense. We had some cost avoidance by decreasing our falls, and here's our graph. You can see here on the graph, these are number of falls in the bar, the fall rate in our unit, and then our mean teaching hospital benchmark. And we had a 50% reduction. So number of falls last year was 5, and we've had 1 this year, 1 this fiscal year. And we really believe that the core behind this is that we were building core strength. We've gotten back to dangling people. If a patient even is on the ventilator, oftentimes they're like this, right? So we just lift your head, Mr. Jones, and just doing some basic head lifting exercises. We do curls, right? What are you doing? You're lifting your head. So just building that core strength and then using that egress test and working collaboratively with therapies. This is very much a nurse-driven protocol and really helps folks to understand that just getting back to those basics made a big difference in our patients. So really the takeaways for any evidence-based project as we've been in our journey in trauma and many of the things we do, it's that daily reinforcement, that daily conversation, putting reminders so that people see what the level is. We also built a progressive mobility accordion that you can find in Epic when you look. So you can look back and see what your patient has been scoring on their level and what they've been doing. And we also really just made it visible with patients and families so they know what our goals of care are. A lot of people have been involved in this project. Many of them have come and gone. But the bottom line is this has been a team effort and making it present and a priority as we work together to achieve positive outcomes. We're doing some additional analysis that looks like our VTE rate is also going to be dropped or lower as well significantly, so more to come on that. What questions do you have, if any? Okay, well thank you very much.